Hello and welcome to JCO Precision Oncology Conversations, where we bring you engaging conversations with authors of clinically relevant and highly significant JCO PO articles. I'm your host, Dr. Rafeh Naqash, social media editor for JCO Precision Oncology and assistant professor at the Stephenson Cancer Center, University of Oklahoma. Today, we are thrilled to be joined by Dr. Christian Rolfo, Associate Director of Clinical Research, the Center of Thoracic Oncology at the Tisch Cancer Institute at Mount Sinai Health System. He's also the lead author of the JCO Precision Oncology article entitled Liquid Biopsy of Lung Cancer Before Pathological Diagnosis is Associated with Shorter Time to Treatment. Our guest disclosures will be linked in the transcript. Christian, it's great to have you here. Welcome to our podcast, and we are excited to learn about some of the interesting results from your study.
Thank you very much, Rafeh. It's a pleasure to be here and discuss about liquid biopsy.
I know you have a very important role in different liquid biopsy consortiums. This is an initiative that you've been leading, spearheading for quite a while, and it's nice to see that it is becoming something of a phenomenon now on the global scale, where liquid biopsies are being implemented more and more in earlier stages, especially. So for the sake of our audience, which revolves around academic oncologists, community oncologists, trainees, and patient advocates or patients themselves, could you tell us a little bit of a background about what liquid biopsies are, and currently, how do we utilize them in the management of lung cancer or cancers in general?
So liquid biopsy was gaining, as you say, an importance over the years. We started to talk about liquid biopsy in 2009 when we started to see some correlations with EGFR mutations. And in practicality, what we are doing is the most common or the most applicable indication is to go for liquid biopsies from the blood, peripheral blood. So we are doing a blood draw, and from there, what we are capturing is the DNA or fragments of the DNA that are still in circulation. But liquid biopsy definition is a little bit more broad, and we can apply the concept of minimally invasive approach to different fluids of the body, including pleural effusion, urine, and including also CSF. That is another indication. There we are going to be a little bit more invasive than the peripheral blood, but it's also an emerging tool that we will have for some specific indications. In cancer, we started the history of liquid biopsy in advanced disease with the identification of biomarkers. And then from there, we was moving to other scenarios, including nowadays monitoring minimal residual disease and early detection. And that's applicable also for other tumors.
Thank you, Christian, for that summary. Now, as you've rightly pointed out, we have come to implement liquid biopsies more and more, both in the academic setting and the community setting. And this has definitely led to faster turnaround time in some ways compared to tissue. In this study that you have authored with the help of many other collaborators and Foundation Medicine, Flatiron Health data, the goal here, from what I understand, was to look at liquid biopsies that were done before, that resulted before pathological diagnosis. Could you tell us a little bit more about the premise of this study, why you thought about this question, and how did you try to implement that idea to get to some of the interesting results that you see here?
Yeah, so what we are seeing generally in lung cancer, and also is applicable for other tumors, that patients are having a journey that started to different doctors, visiting different doctors until they get a diagnosis. And generally, after the pathological diagnosis, if you don't have an in-house technology that is doing a reflex testing, generally oncologists need to request for the testing, and that is taking time. So if we are looking for the comprehensive days until the patient's able to get a molecular profiling before we start the treatment is sometimes very long. And we are talking in some cases about months. So how we can speed this process? And that was the main question. And we try to include liquid biopsy in the staging procedures of this that we generally are doing when we have a clinical diagnosis of lung cancer, beside the images that we are used to do, a PET scan, MRI, and other kind of assessments. We want to include liquid biopsy there before the biopsy. And that's what we did. And we was searching for this specific aim using the Flatiron Health, the Foundation Medicine electronic health records. from 280 centers around across the United States. And we include a big number of patients in this analysis, more than 1,000 patients for the first analysis.
And that's phenomenal that you had data, real world data from 200 plus centers across the US. Of course, when you have patients on a clinical trial versus patients in the real world, we all know that there are differences in terms of approaching, overseeing, managing these individuals. So this data set is an extension of what we see or could see in the real world setting. Could you tell us a little bit about the number of patients that you eventually identified that had liquid biopsies done before pathological diagnosis? I think you have different cohorts here, a group that was before, a group that was after. You compared several important metrics treatment-wise from what I see. Could you highlight those for our listeners?
Yeah, so we was looking for patients who have a liquid biopsy, the CGP, so the clinical genomic profiling order within the 30 days pre-diagnosis and post-diagnosis. And we focused in 5.2 patients that were corresponding to 56 patients who ordered a liquid biopsy before diagnosis. The median time was 8 days between the order and diagnosis, and the range was between 1 and 28 days. And that was compared with the 1,020 patients that we ordered liquid biopsy or were ordered liquid biopsy after diagnosis. It's important to hear that these patients, both cohorts, have similar stage and ctDNA tumor fracture. And there we can explain later on what is tumor fracture because it's done in addition with a paper that we just published last week. Liquid biopsy in the patients was resulting to have this CGP in a median of 1 day after the diagnosis, but 25 days after patients who have the diagnosis and liquid biopsy later on. So from these patients, the majority of them, of the patients that is 5.2 patients or 56 patients, 43% of these patients have positive drivers by NCC guidelines. And 32 of these patients have this ctDNA tumor fraction more than 1%, but the driver negative. So that is what we call breakthrough true negative. And here maybe I can explain what is tumor fraction and in general that is also used in this definition.
I think that would be great for the listeners. We see this often in more and more liquid biopsy results nowadays, and I've tried to explain it to some of my fellows also. So I think it'd be nice if you explain for the sake of our listeners what tumor fraction is, what does it mean clinically? Can you use it in a certain way? What biological relevance does it have?
So we are analyzing another paper that came out this week on clinical cancer research, the concept of tumor fraction. And it's a new definition. So what we are doing in tumor fraction is an algorithmic calculation or mathematical calculation on the aneuploidy of the cells, also taking in consideration the BAF, the quantity of DNA present in the sample. So we are going very low in the sensitivity of this analysis and capturing there the real informative results of the ctDNA of the liquid biopsy. So in practicality, when you see a report that say a threshold, the threshold that we established in this study was more than 1% or less than 1%. So in patients who have tumor fraction more than 1%, we can really consider that this liquid biopsy informative. And also in this next publication, we compare with tissue. So patients who have tumor fraction more than 1% were completely 100% corresponding what we found in the reflected tumor tissue, the NGS. But what happened with patients who have tumor fraction less than 1%, we consider that these patients were not informative. So we need to wait for the tissue biopsy results coming because we were able to recuperate several patients that the liquid biopsy was negative with the tissue biopsy positive. So this is an important concept because we are distinguished not only the informative of liquid biopsy, but also we can distinguish between patients that are considered not cheaters, patients that are considered cheaters. And that was a problem until this kind of introduction was a problem before with the technology because the technology was very bad to distinguish like sensitivity or high sensitivity. But now the sensitivity is not more a problem. Maybe the really value of information, what we have in liquid biopsy, and using this mathematical help, we can get these patients also distinguished and help more people. So that would be really interesting.
You touched on a few important concepts here. One question I have, and I think there's no better person to answer this question. You're the right person to answer this question for our audience. Do you think when you have a liquid biopsy tumor fraction of less than 1% and you have a tissue that is pending with an NGS, or tissue NGS is not resulted yet, but liquid biopsy results come in and tumor fraction is less than 1%, but let's say you have a non-smoker, typical driver mutation, clinical characteristic positive individual in the clinic, and tumor fraction is less than 1%, how much can you trust that liquid biopsy, the tumor fraction is less than 1%? Because do you think some of these driver mutations, like you mentioned, could be low shedders and you could miss a potentially actionable mutation on a liquid biopsy if the tumor fraction is less than 1%? Is that something that you've looked at or correlated or understood? Like, what would be the clinical meaning of that?
Absolutely. So there are two concepts here. A liquid biopsy could be non-informative, and that is what we saw in this paper. So you have patients that have liquid biopsy negative, and that we see in clinic, liquid biopsy negative, liquid tissue biopsy positive. That could be because the liquid biopsy is not informative, but could be also that the patient, for some biological reason, and we don't have an answer about that, they are not shedding in the bloodstream ctDNA that we can capture. What we saw in different studies, including one of the papers that we presented also in ASCO last year with the MET amplification for MET exon skipping mutation, for example, in the study that was the vision study using tepotinib. You see that patients who have liquid biopsy negative are doing better outcome compared with the patients who have liquid biopsy positive. So I believe that we have still firmly patients that are not cheaters for some biological reason. That could be putting together patients that have more bone metastases than organ metastases, patients who have more locations, for example, in the brain. So these patients are difficult to capture in ctDNA, some biological reasons, but also you have patients that are non-cheaters for the technicality of the product. So this tumor fraction analysis is really important to distinguish that, and we will hear more and more. So as you say, we have already some reports, some companies like Foundation is doing, but some others like Tempus Garden and others are trying now to incorporate this tumor fraction. And several in-house technologies allow also to have this kind of mathematical calculation. So that is what we are facing now to really understand better the power of liquid biopsy.
Now, some of the other things that your project or paper that you published with JCOPO does not necessarily cover is the payer aspect of this. Now, we've had more and more discussions, obviously, and more information has been highlighted with the payers that this is an important test. It needs to be reimbursed, even though if you do tissue NGS, liquid biopsies are complementary to tissue. So taking both together is probably a better view of the overall tumor and the mutational status of the tumor. But one of the biggest holes in this whole process, and this is my personal experience, I want to know what you think, is we can't order these tests when the patient is admitted to the hospital. And 50% or more patients end up getting diagnosed in the hospital during an inpatient stay. Average hospitalization for somebody with lung cancer is, 5 to 7 days on an average. And then another 1 to 2 weeks to get into the clinic to see an oncologist. So what would your thought be there? How can we improve things there in terms of, can we try to do something different so that the payers agree that, yes, you can send a liquid biopsy when the patient is admitted, because there's that 14-day Medicare rule. Has your team or have you in particular tried to navigate some of those issues? And what would your thoughts be of how we can try to improve some of those conversations?
Yeah, that's a really good question, because here we are talking about inequities in access to the technology and the results, and it's crucial. Several of our patients, specifically in lung cancer, they are coming to our consultations or to the emergency with a very bad situations, and they need to be admitted immediately. And as you say, they can be there for 1 month waiting for results or to recovery or to stabilization of the general condition that we can start. Several of these patients could have some biomarkers that we can have a treatment. So in poor words, I will say that this is a stupid rule, because we cannot have in 2024 these kind of limitations to access to the treatment when we have, from one side, FDA doing a terrific job to get approved drugs in very short time, And from the other side, we have payers that are not understanding the concept of molecular or precision oncology. So what we are trying to do in these patients, to be honest, we try to navigate with the vendors and try to get this done. I generally send the samples because I consider personally that this is a very crucial information. And in several cases, we have started targeted therapies when the patient is still admitted. So I think it's something that we need to put together a better effort because already we are not doing in outpatients. If you look the data of the My Lung consortium that were presenting in ASCO some years ago on the testing performance in the community practice, 50% of the patients with lung cancer are tested. We are going to some minority groups, African Americans, 39%. So I think we need to do better in education, but also from the payer side, it's really crucial that they understand this concept. Advocacy groups have a lot of say here. They were doing also an important job on that. We are now launching with ISLC, ISLB, Lung Cancer Europe, and Longevity, and a survey that is to make also the patients aware what is the importance of molecular profiling, tissue or liquid biopsy. Here, the important is that you get something to treat the patient and select the right treatment. And even to say immunotherapy could not work in your case. So that is really important.
Absolutely. I completely agree. We've made a lot of strides, but there's still a lot of room for improvement in terms of equity, access, and reimbursement. Now, one of the things that I noticed in your paper, and you could tell me a little bit more about, is when you looked at the pre-diagnosed liquid biopsies, meaning before tissue diagnosis, 56 individuals there suspected to have lung cancer, community testing or community-based testing was identified in 53 individuals versus academic being 3, which is very encouraging when you see something like this happening in the community. Did you look at that? Did you try to understand why or how that was the case? Because I would, in a general community setting, think that community practices have a more complicated system of reimbursement because they're dependent on direct reimbursement versus bigger academic centers. There's some leeway here or there. So did you try to understand how they were able to order this before tissue? Could you give us some insights there?
Yeah, I think we was not digging in this specific question, but it's a very interesting topic because we generally in academia, we believe that we are doing the things in advance and we are more compared with the practical, with the general practitioners or the general oncologists in the community practice. We have more resources. But sometimes, and it's true, obviously, we have more resources in terms of research and more opportunities in terms of clinical trials in some cases. But I think we understood with this minimal example that there is an important interest from the general oncologists in the community practice to get this done. And this is something that we need to emphasize because sometimes we are putting the blame on our colleagues that are outside the academic centers on this lack of testing. And it's not really true sometimes. So this is a good point to start to work together and try to get more things done for our patients. Try to get also the reality. I think one of the problems that we will have in the future that we can face right now is the lack of new figures in this molecular profiling. And I'm referring, for example, molecular nurses or personnel that is working, helping to get this done. We need to have more people that is working in this education for the patients, in the access to the treatment and access to the technology, but also to navigate better these problems with payers that sometimes in some patients seem to be overwhelming because when you even talk about the $100 that could be extra, it's fun for some patients. So we need to be very conscious about that. So having a new figure in the hospitals and the community practice could help this to get more tested patients.
And I think at the end of the day, the payers or the reimbursement mechanisms, they need to understand that genomics is part of the diagnosis these days. It's not ancillary. It's not in addition, but it is part of the diagnosis. And I'm pretty sure you've had similar instances where you get a confusing pathology result, but then a genomic result points in a certain direction. You treat the patient in that direction, and then you see the patient benefiting and the tumor shrinking, which suggests that genomics is complementary to the path diagnosis. It's not necessarily a surrogate. You can't replace pathological diagnosis, but you can use genomics as a complementary diagnosis as part of the whole paradigm of treating the entire patient. So I think we definitely need more and more conversations like the ones that you're having or your liquid biopsy consortium is having, and then more education from the FDA, of course, more legislation, more advocacy. Going back to the paper, I did notice another interesting thing which is again very encouraging, is patients with cancer, like lung cancer here, performance status of 2 or above, a decent proportion actually had testing done, which again points out to this important concept of this preconceived bias, avoiding that preconceived bias that, hey, if somebody is not a great performance status, testing and finding something in that individual could potentially change a lot for that individual. Do you have any personal examples from patients that you've treated or seen in the clinic for our listeners where you identified something and maybe they were not doing as great initially, and then you identified something, a liquid biopsy treated them, and it changed the entire course of their illness and whole trajectory for them?
Being working in lung cancer for years, everyone have this kind of patients that we see that the performance status was very bad. Here, we obviously, as a clinician, we need to identify why the performance status is deteriorated. So if it's to the disease or some of our patients, we know in lung cancer, several of them, they can have a very important comorbidity package that is associated with lung cancer. So in patients who have a deterioration for lung cancer, and we find a driver, have some patients that were doing a kind of a weakness, and that is something that we see in several patients, specifically in patients even with leptomeningeal disease in some cases, when we start to do drivers that have a big impact in crossing the hematoencephalic barrier, and have a good response. I have some patients that have an important recovery. So this is something that we need to distinguish. And sometimes when the patient is very bad, they say, okay, we'll go directly to palliative care or supportive care. So try to test these patients as well, because these patients can have an important impact in the quality of life if we are treating. Obviously, we will not be able to cure patients this setting with targeted therapies, but we can certainly impact in the quality of life and also in outcome of survival.
One of the other questions that comes up often when you're in a multidisciplinary team, since most cancers these days are often multidisciplinary decision-making opportunities to treat the patient the best possible way, is who orders the liquid biopsy. So I remember from my fellowship several years back, our program director, Paul Walker, who's again an amazing lung cancer thoracic oncologist, he had advocated that our endoscopic suite folks, the bronchoscopists, whether it was pulmonary, interventional pulmonology, or CT surgeons, whoever did the bronchoscopy for the first time in the patient, that they would send it whenever they see the patient from the bronch suite. So this was 6-7 years back. And I think Paul was a little ahead of his time, and I didn't necessarily understand the implications that this would have. And now as I have progressed in my own little career, I can see the vision that he had, which I think a lot of other centers have tried to do, and pretty sure you have a certain process too. So is that something we should try to talk more and more about? Because of course, when you do the bronch, then you get a diagnosis and the patient sees the oncologist. This whole process takes anywhere from 2 to 3 weeks, maybe even more for smaller centers. So is that something that you're doing, or you see that you're having more conversations that, hey, whoever sees the patient first should be able to order the liquid biopsy? It's not necessarily the medical oncologist. Yes, I mean, I love to order sequencing results or sequencing tests, but it could cause a delay in the patient care. So could you tell us a little bit more about it?
Yeah, so it's really important, this part, because we need to create in our institutions flows that we have this very well organized. And ideally, so in the ideal world will be that we have reflected tests coming from the pathologist, but it's not happening in several places because we don't have our NGS at home, or we are sending to vendors, and the pathologists are not sending to vendors. So that is one of the aspects. The second aspect, and that I think is still a problem in some institutions, we have still cytologists coming out in place of core biopsies. And in our institution, we was working very hard with our interventional pulmonologists and interventional radiologists to get this quality of tissue appropriate. And we have a very good rate of success in tissue sending, and very minimal quantity insufficient. But obviously, some patients are very difficult to get samples, and we need to recur still to cytology. But in some cases, our surgeons or our pulmonologists are sending samples for NGS. And I think this is, or we are coordinating. I will see this patient next week. Can you please start to order? And here, our nurse practitioner, our nurses in the team are also playing an important role. For the reason I insist in the idea to have new figures that could be these molecular navigators, we can call, or molecular nurses that help in coordinate this, not only in the coordination, but also in the discussion of molecular tumor boards. And we did an experience like that some years ago at Maryland University. And actually it was a very important opportunity to decrease the number of quantity patients and get the results done very quickly. So I think it's important to have conversations with our colleagues, pulmonologists, radiologists, interventional radiologists, pulmonologists, and pathologists to get this done very quickly.
I love the idea of molecular navigators. And of course, everybody in the current day and age, we are having staffing issues. So getting a molecular navigator would be awesome, but I'm not necessarily sure how everybody would be able to implement it. But I think in the bigger picture, whether it's molecular navigators or multidisciplinary nurse navigators in general, liaisons in general, I think we all can do a better job in trying to coordinate some of these testings. And we have tried to do that within our thoracic oncology group. And of course, there's lots of progress that need to be made, but one step at a time. So,
no, and actually, if somebody is interested on this topic in the International Society of Liquid Biopsy, we started with a project that is called a Certificate for Advanced Studies in Precision Oncology. So we are educating the healthcare team for all this process and try to get practical insights to have this career later. Because I think will be something that is interesting for nurses, for pharmacists to get this kind of career later for yet another approach in their career.
Thank you so much, Christian. Now, going to the not so scientific part, which I think is the most interesting part of this conversation, is to talk about you and your personal journey. So could you tell us a little bit about where you started, what your career has been like, how you've progressed? Because we have a lot of junior faculty that listen to this, and it's always good to take inspiration from people like yourself.
Oh, thank you. So as you can hear, my accent is not from here. So I was born in Argentina. I did my medical degree there. And then I got the opportunity to get a scholarship in Italy. I went to Italy and I stayed there for 7 years. I did my fellowship there again. And I started to know their precision oncologists. The journey started with sarcoma. And actually, I was working in the group of Dr. Casali, that is a very well-known sarcoma expert. And at that time, we're running the phase 1 trials of imatinib, I remember, for GIST. And I saw this kind of response and awakening of patients that were really in very bad condition, responding to this imatinib, very lethal disease that was GIST at that moment, with a median overall survival of 2 months. So I started to be interested on that. Then I moved from there to Spain, and I met Dr. Rafeh Naqash. That was my mentor. In Italy, I have also a mentor in breast cancer. That was Dr. Lucajani, one of the pioneers in breast cancer treatment. So knowing all these people and having the support of them was really crucial. So I think this is the first advice for the junior faculty: try to choose your mentor, even if your mentor is not in your center. Like the case, for example, Rafeh Naqash was not in my hospital, but he was my mentor. So having this kind of discussion, I did my PhD on EGFR mutation. At that time was the fashion, not immunotherapy of the moment. And then from there, after 8 years in Spain, I moved to Belgium. I have an period of short training in the Anderson, and I went to Belgium to Antwerp University. And that was the opportunity to become the director of phase 1 program and clinical trial management program. Was really exciting to see growing a unit. And nowadays, this unit's a referral center in Belgium, and my colleagues that stay there, they are doing a terrific job continuing this idea. And from there, I went to Baltimore, 3 years working in Maryland University, being the director of thoracic oncology and early clinical trials as well. 3 years after, I moved to New York, and here doing this journey in clinical research, also being the director of clinical research in the Center of Thoracic Oncology. So it's, the life is putting you in different places, different cultures, different opportunities. For me, it was a really a good journey to be in different countries, knowing different ways to see oncology as well, and media to work, because it was a shock coming from Belgium to the area of Baltimore, when I have to the reality to discuss peer-to-peer conversations and things that are not usual discussing in Europe. So it was really a very, very nice journey to learn and to have the capacity to adapt. That is the other thing that the second advice, try to have, if I can give an advice, obviously I'm very simple on that, but if you have the opportunity to go to some place, adaptation is the most important thing. So this is the way, and try to enjoy what you are doing, and try to enjoy and learn from the patients and from colleagues, and contribute with your baggage as well.
Thank you so much, Christian. Two last questions. For all the places that you visited, what's your favorite place and what's your favorite food?
Oh, my favorite place for live, maybe, I have Italy in my heart. Obviously, Argentina is my place, so family, but Italy is in my heart. And then Spain. Spain gave me my wife and my son. So I have a very good memories there, and it's a very nice place. And obviously I'm Argentinian, so for me it means meat in some cases, and and asado, that is a typical Argentinian one. But also I'm very good enjoying the pasta and paella. So we have several things, and even here in New York, even the pizza of New York is great. If it's not Italian, this a new way to do the pizza from New York is fantastic.
I can try to see you're trying to keep everybody happy in a politically correct way.
I didn't mention Belgium, but we have chocolates there coming that are fantastic.
That is true. Every place is special and unique in different ways. Christian, thank you so much. This was very entertaining, very informative for me and hopefully for the audience. Thanks so much for being a part of this conversation today. And thank you so much for submitting your work to JCOPO. We hope you consider JCOPO for future research in this exciting area as well.
Thank you. Thank you very much, Rafeh, for the opportunity. And JCO Precision Oncology is a really great forum to discuss precision medicine, and congratulations for all your work. And the last, if you allow me to give an advertisement here, we have our liquid biopsy congress, the ISLB. The annual congress will be in Denver from 22 to 25 November. So just before the Thanksgiving days. So if you are able to go there, we will have a lot of discussion on liquid biopsy like we did today. Thank you very much.
Thank you so much for highlighting that. And hopefully the listeners will try to register and be part of that meeting. Thank you for listening to JCO Precision Oncology Conversations. Don't forget to give us a rating or review, and be sure to subscribe so you never miss an episode. You can find all ASCO shows at asco.org/podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.